I'd like to ask Jennifer Goldstein and Zugui Zhang to come up. We call this section Notes from the Field. Their presentation is going to be, is utilization and out-of-pocket spending for hospital outpatient observation care higher for our most vulnerable neighbors? Please. Thank you. Actually, there is one caveat. This particular work, actually, when they published this, actually was reported in Reuters and got national press very, very quickly, and even you were on NPR, or if I'm not mistaken, right? So we should be very proud of what they've accomplished. Okay.
Thank you. So good morning, everyone. My only disclosure today is that both of my parents are Medicare beneficiaries. So I'm a hospitalist with CCHP, and every time I bring a patient into the hospital, the first order that I place has nothing to do with the care that I provide. It has to do with how they'll pay for it. Medicare has two types of hospitalized patients: inpatients and observation patients. These patients are indistinguishable on the medical floor, but observation patients are at risk of unlimited out-of-pocket costs, while inpatients are protected. So how do we differentiate inpatients versus observation patients? Well, it's a little bit more art than science. In 2013, CMS created new rules. This was called the 2 midnight rule. And under this rule, as a hospitalist, when a patient comes into the hospital, it's the physician's job to determine whether that patient is going to require more than 2 midnights worth of care in the hospital or less. If the admitting physician believes that the patient is going to require more than 2 midnights, they need to place an inpatient admission order. If they believe that the patient is going to require less, we have to put them under observation status. So why the concern over cost? Well, inpatient stays are covered by Medicare Part A. Part A requires a hefty deductible from the patient, but that deductible covers practically all of the care in the hospital, and it also covers care in a skilled nursing facility after the patient leaves the hospital if that's necessary. Observation patients, on the other hand, are covered by Medicare Part B, which has a different cost-sharing structure. These patients are required to pay a 20% copay for all of the hospital services they receive, and they do not have skilled nursing facility care covered under Part B, which means if they had to go, they would need to pay that out of pocket. So essentially what you're talking about with observation care is hospital-level care with a greater copay for patients coming out of their pockets and less access for them to post-acute care after they leave. Well, this is problematic for many Medicare beneficiaries because many of them don't have a lot of money that they can spend on out-of-pocket healthcare costs. Many of them are also frail, and even a couple of days in the hospital will leave them too debilitated to take care of themselves when they go home. This raises the anxiety level of some of our observation patients, and it leads to some pretty basic questions that are actually pretty hard to answer, like how am I going to pay for this, and where am I going to go? These two questions are at the core of the papers that we'll discuss today.
For our first research, we asked 2 questions. First, whether low-income beneficiaries are at risk for high utilization of observation care. We define high utilization as 3 or more observation visits in 1 year. The second question is whether low-income beneficiaries are at risk for high out-of-pocket cost for observation care. We define high out-of-pocket cost or high financial liability as the total out-of-pocket cost more than Part A deductible, which was $1,184 in 2013. To answer these questions, we used a nationally representative sample of Medicare beneficiaries, and we look at the Part B claim data in 2013. We selected patients with 1 or more observation stays. We connect our data in income and poverty rate from a US Census in 2013. We combine the 2 data sets on county code And then we have a combined data set in which each beneficiary was linked to the poverty rate from the county of their residence. And then we divide the sample into quartiles on poverty data from the wealthiest to poorest. In our research, the wealthiest quantile represented the beneficiaries who live in counties where less than 12% of population under federal poverty level. And the poorest quantile represented the beneficiaries who live in counties where more than 19% of population under federal poverty level. For the statistical analysis, we calculated frequencies, means by poverty quartile for demographics, utilizations, and liability. We used the ALOA technology to compare the differences between poverty quantiles. Logistical regression were used to evaluate the independent correlation relationship, poverty quantile and high utilization, as well poverty quartile and high liability adjusted for other variables. In our data set, out of about 56 million claims, we had about 132,000 observation stays, representing 7,600 unique Medicare beneficiaries in our data set. All of 50 states and more than 97% of counties nationwide are represented in our analysis. When we look at the relationship between poverty quartile and high utilization, the poverty quartiles were arranged from wealthiest to poorest, and we adjusted for other variables. We can say that the risk of high utilization increased with each poverty quartile. And also we can see that those in poor and the poorest quantile are at a significantly higher risk of high utilization. When we look at the relationship between poverty quartile and high liability, we can see that compared to the wealthiest quartile, we can see the risk of high liability increased for each other quantile. And we can see the risk peaked at the third quartile, which represents for the poor, but not for the poorest beneficiaries.
In summary, what we found is that Medicare beneficiaries from low-income backgrounds appear to be at risk for high utilization of observation services and high liability for observation care. We also found that poor beneficiaries may be at even higher risk for high out-of-pocket spending than the poorest beneficiaries, even after adjusting for utilization. This might seem counterintuitive, but it falls in line with prior research that's found that the near poor or working poor are at the highest risk for high out-of-pocket spending for health care. Our second paper examined whether there was an unmet need for post-acute care among our observation patients, and whether such a need might be associated with worse outcomes, such as increased length of stay or increased 30-day rehospitalization. This was a retrospective observational study, and we did it using ChristianaCare data. We looked at all beneficiaries who were hospitalized under observation status for the year 2013, and we selected a random 30% sample to look at whether they'd received a physical therapy evaluation, what the physical therapist had recommended for them in terms of disposition, so whether they thought they should go to skilled nursing facility, home physical therapy, or home without services. We looked at where they actually went. And then we looked at outcomes based on what the physical therapist thought they should receive, including adjusted length of stay and 30-day rehospitalization rate, which was a composite of emergency room, inpatient, and observation. So out of 1,400 admissions or 1,400 observation stays for Medicare beneficiaries in 2013, we reviewed 386 charts and found that about 50%, or 181, had received physical therapy evaluations. From that group, 17 out of 181, about 10%, were actually recommended to go to skilled nursing facility. But remember, that's not covered under Medicare Part B. They would have had to pay for that out of pocket. One patient actually went to a skilled nursing facility. Among patients with a recommendation for skilled nursing facility, their length of stay was significantly higher, at about 75 hours. And those patients also were much more likely to come back to the hospital. They had a 52% rate of rehospitalization compared to their peers. So in conclusion, we found that many observation patients physically qualified for skilled nursing facility placement, but most went home, and outcomes were worse for those patients. So what can we glean from these two papers regarding observation policy as it stands today? Well, it's not great for patients. It appears to place vulnerable beneficiaries at risk for high out-of-pocket costs, and it limits access to skilled nursing facility services, which may ultimately lead to higher downstream utilization. It's also not universally great for hospital systems. In general, revenue from observation-level care falls far below that of the inpatient equivalent care. Additionally, for hospital systems like ours that have accountable care organizations, policies that potentially increase downstream utilization are not in our favor. So how do we serve our observation patients with excellence and love? Well, I'm very proud to be part of an organization that's thought a lot about these questions.